Neuromuscular Disorders, including multiple sclerosis and Guillain-Barré syndrome, by Emily, Jordan, Elena, Abby, Megan, Noelle, and Caleb.
Multiple sclerosis is an autoimmune demyelinating disease of the central nervous system. MS is multifactorial, with both genetic and environmental factors linked to its incidence. Exposure to UVB light and exposure to the Epstein-Barr virus have been implicated as environmental factors that interact with genes that lead to the onset of MS. The loss of myelin leads to axon dysfunction, which slows and distorts nerve impulses. Medications are used to slow the progression of the disease, decrease the number of exacerbations, and treat the manifestations of MS. Risk factors for MS. The onset of MS is usually between ages 20 and 40. MS is primarily a disease of people of Northern European ancestry. Risk for developing MS is 15-fold greater when MS is also present in a first-degree relative, and even higher in monozygotic twins. Those with human leukocyte antigen, HLA, DR2, haplotype are especially at risk, although the reason is unknown. In the United States, approximately 400,000 people have MS. The incidence is approximately 1 in 2 million worldwide. Women are more affected than men, about 2 times more affected. The disease is also more prevalent in colder northern latitudes, like the northern Atlantic states, the Great Lakes region, and the Pacific Northwest.
The manifestations and systems affected depend on the location of demyelination. These manifestations can last from days to weeks and sometimes partially resolve. Most common symptoms include sensory loss, visual deficits, weakness, paralysis, ataxia, and vertigo. Fatigue has been noted as the most disabling symptom of MS. In most patients, the initial manifestation includes blurred vision, red-green color distortion, or blindness in one eye. Of myelin in the spinal cord, brain, and optic nerve causes plaque buildup that inhibits nerve impulses. This inhibition of messages causes blurred vision, fogginess, diplopia, poor color perception, decreased visual acuity, and altered pupillary reaction to light. Brainstem lesions can lead to nystagmus, deafness, vertigo, tinnitus, decreased sensation, and cognitive dysfunction. Changes in mood can also be evident with plaque formation, such as depression. Upper motor neuron involvement manifests as stiffness and weakness in the extremities. Bladder and bowel dysfunction is also affected. Destruction of the myelin sheaths in the CNS can also result in sexual dysfunction.
Therapeutic holistic care for multiple sclerosis focuses on retaining the optimal level of functioning possible through rehabilitation, physical therapy, occupational, vocational, and psychosocial therapy. Management of MS varies according to the severity of the manifestations. During exacerbations, the focus will shift to controlling the manifestations and quickly returning to remission. Lastly, recent studies have focused on neuroprotection, which appears to limit the degeneration associated with MS. Neuroprotection combines specific brain imaging techniques, which measures the actual volume of the brain with new medications. And here, this link is from Cleveland Clinic, which actually will provide you with more examples of alternative complementary therapies. Psychosocial impact of MS. We'll begin with cognition. So researchers have made strong efforts in the last decades to fully comprehend how cognitive problems develop in patients with multiple sclerosis. They are also working towards developing strategies to lessen the effects of the disease. MS differs strongly from cognitive changes that occur in Alzheimer's disease. The functions that are mainly associated includes memory, complex attention, speed of information, planning, visual perceptual abilities, and word finding. Functional magnetic resonance imaging has been used by researchers to correlate particular cognitive deficits with abnormalities in specific areas of the brain. These scans are administered while the patients are performing different tasks in order to determine which area is being altered. In emotion, the initial emotion reaction to the disease is a big component of the psychosocial aspect. The patients realize that their life is going to be severely altered. Also, in addition to the emotional Reactions to the disease, MS-related tissue damage in the brain, can also result in emotional changes. A team funded by the society found evidence that depression is linked to brain volume loss in specific subregions of an area called the hippocampus, which is known to be important in memory. And then lastly, in pediatrics, the Pediatric MS Centers of Excellence, funded through the National MS Society Promise 2010 campaign, works to fill information gaps, creating a standardized battery of cognitive tests to assess function, conducting research, and providing important resources for parents and children. In particular, the Society has played a key role in bringing cognitive issues to forefront in children with MS. Little had been documented about how cognitive impairments may affect children with multiple sclerosis. Here is a list of several different community resources for multiple sclerosis.
Decreased planning ability. Manifestations in nutrition include difficulty chewing, dysphagia, bowel incontinence, or constipation. Mobility includes fatigue, limb weakness, ataxic movements, spasticity, muscular atrophy, and dragging a foot or foot drop. Perfusion includes impaired retinal tissue perfusion. Sensory manifestations include blurred vision, diplopia, nystagmus, blind spots, eye pain, numbness, paresthesias, diminished sense of temperature, pain with spasms, and loss of proprioception. Lastly, oxygenation may also be affected. Manifestations include diminished cough reflex, which leads to compromised airway and respiratory infections. Guillain-Barré syndrome is an acute inflammatory demyelinating disorder of the PNS characterized by an acute onset of motor paralysis. This disease is characterized by a progressive ascending flaccid paralysis accompanied by paresthesis and numbness. About 20% of patients have respiratory involvement to the point that ventilation is required.
Hi everyone, my name is Megan Rudisil and I'm going to be talking to you about the risk factors for GBS. So GBS is one of the most common PNS disorders affecting about 3,500 people in the United States and Canada each year. Of those, 40% typically have no precipitating factor. However, infection with Bacterium Campylobacter jejuni is one of the most common risk factors for these patients. People can also develop GBS after having the flu or other infections such as Epstein-Barr virus. GBS is a rare and acute autoimmune disease. It affects men and women in equal numbers. In addition, it has a similar morbidity across all age ranges. Okay, now we're going to talk about the signs and symptoms of GBS. So in this syndrome, typically muscles, sensory nerves, and cranial nerves are all affected. The first symptoms that are usually seen are numbness and tingling in the toes and fingers, which sometimes progresses to weakness in the arms and legs over a series of days. Some patients experience paresthesias only in their toes and legs, others only experience symptoms on one side of the body or another. The symptoms may stay in this phase, causing only mild difficulty in walking, which can require ambulatory aids. However, sometimes the illness progresses, leading to complete paralysis of the arms and legs. About 1/4 of the time, the paralysis continues up the chest and freezes the breathing muscles. This can leave the patient dependent on a ventilator. If swallowing muscles are also affected, a feeding tube may also be needed. So there are 3 stages of GBS. In the acute stage, weakness occurs in at least 2 extremities and advances and reaches its maximum in 2 to 4 weeks. 20 to 30% of these patients with GBS need mechanical ventilation. In the plateau or stabilizing stage, symptoms are at their most disabling, with little or no change over a few days or weeks. Then, in the recovery phase, remyelinization and axonal regeneration occurs over a period as long as 2 years. Recovery tends to start at the head and neck and travels distally. Most patients experience significant, if not complete, return of function, with fatigue as the most common reported residual symptom.
This is Caleb Tice recording on the complications of Guillain-Barré syndrome. Complications depend on the nerves being affected by the demyelination. Respiratory function may be affected due to paralysis of intercostal and diaphragmatic muscles. Supportive care and ventilatory assistance may be needed. When the autonomic nervous system is affected, manifestations may include fluctuating blood pressure, cardiac dysrhythmias and tachycardia, paralytic ileus, syndrome of inappropriate antidiuretic hormone secretion, and urinary retention.
Therapeutic holistic collaborative care for GBS. Interprofessional care for GBS includes interventions during the acute phase, which is 1 to 3 weeks, that focus primarily on ensuring oxygenation via ventilatory assistance, as well as ways to prevent complications related to immobility. Rehabilitation time to regain muscle strength and function varies from patient to patient, but most people return to full pre-syndrome muscle function within 6 months to 2 years. Care of the patient with GBS requires a collaborative approach. From the initial acute phase through rehabilitation, many members of the healthcare team are involved. An accurate and rapid diagnosis is needed to ensure prompt supportive treatment, particularly if there is a respiratory involvement combined with widespread paralysis. The acute neurological deficits that accompany GBS can lead a patient to be physically helpless, especially with the need for mechanical ventilation in an ICU. This feeling of helplessness is often coupled with anxiety, disorientation, and terror. GBS also causes problems with communication, swallowing, and bowel and bladder function. All of these complications can lead to an increased emotional problems like poor self-esteem, altered body image, social isolation, and fears. Psychosocial support is imperative for patients with GBS. Patients and family members are frequently stunned by the rapid deterioration of function and fear that the paralysis will be permanent. Regularly reinforce teaching because the patient's high anxiety level may interfere with listening and understanding. When possible, include the patient and family in decision making. Seek their input when planning a daily schedule of care that incorporates various therapies.
This is Caleb Tice recording. For community resources, the GBS CIDP Foundation International is a global nonprofit organization that supports patients and families living with Guillain-Barré syndrome. Their vision is that those affected by GBS will have access to early and accurate diagnosis, appropriate treatment, and knowledgeable support services. Their mission is to support and nurture patients, educate clinicians, fund research, and advocate at the federal, state, and grassroots levels to educate policymakers to make informed decisions that benefit the GBS community. This is the concept map for Guillain-Barré syndrome. For perfusion, involvement of the autonomic nervous system is characterized by fluctuating blood pressure, cardiac dysrhythmias, and tachycardia, paralytic ileus, syndrome of inappropriate antidiuretic hormone secretion, and urinary retention. For mobility, patients with GBS usually become immobile as the disease progresses. For cognition, the level of consciousness and cognition are not affected. Patients with GBS are likely alert, but often become mute. Their functional ability. Patients with GBS usually require prolonged rehabilitation care, which begins during the acute phase and focuses on preventing complications and limiting the effects of immobility. The severe muscle atrophy and loss of muscle tone require that patients relearn many functions and skills, such as walking. For nutrition, nutritional support for the patient who is immobilized for prolonged periods of time is crucial. These patients have difficulty chewing and swallowing. TPN may be indicated. Sensory perceptual. Weakness and sensory loss most often ascends to the upper extremities, torso, and cranial nerves. Sensory involvement includes severe pain, paresthesia, and numbness. Oxygenation. respiratory dysfunction, and a decrease in vital capacity. These patients are typically ventilator dependent.